Everybody, it's Dr. Eric Balcavage, and I'm with my partner in crime, Dr. Riggleman. Hello,
Hi.
Dr. Riggleman. And we are back for another edition of the Thyroid Answers Podcast, and we have a special guest today, a fellow ShyCon participant, Dr. Shelese Pratt. She's a naturopath, and she is going to talk to us a bit about the connection between hypothyroidism and Down syndrome, something I did not have a lot of experience researching, but we're thrilled to have her on so we can learn a little bit of her perspective on thyroid physiology and what she sees in some of her patients who are Down's patients. So Dr. Pratt, welcome to the podcast. How are you?
I'm great. Thank you so much for having me.
And I know you travel back and forth from Midwest to the East Coast. Where are you today?
I'm in Louisville, Colorado today.
Awesome.
So this is where I live. This is where I primarily practice, but I do have an office in Fairfield, Connecticut as well.
God bless you. It's hard enough having two within a 5-mile radius, but I gave that stuff up. But let's start by give us a little bit of your background. How did you get into functional medicine and naturopathic medicine, and how did you start working with Down's patients?
So I was really sick when I was young, actually, and I was headed towards traditional medical school. And I got to the point where I was put on so much prednisone for so long that it started impacting my other functions. I started getting ulcerations all along my GI and throughout my bladder. I ended up having so many complications. I ended up with shingles, everything, because I was on so much prednisone to control my asthma. And it was through naturopathic medicine that I was actually healed. And I had read Andrew Weil's book to find naturopathic medicine, Spontaneous Healing, way back when, in I guess that would have been 1995. And then I read the Naturopathic Oath and said, oh my gosh, that's exactly where I want to go. So I started naturopathic medical school in 99, and I finished my degree and had a child. In 2004 or 2003, I had my child. In 2004, I finished my naturopathic degree or medical degree. So I got into special needs children pretty much early on. I've always been interested in pediatrics. That's always been an area that has been interesting to me, and neurology is somewhere that I feel like it's always made sense to me and always pushed me in understanding. And so back in, 2008, I became a Defeat Autism Now doctor, a DAN doctor, and really steeped myself in biochemistry back then, and was hearing Jill James speak and all these wonderful functional medicine doctors. And I just kept going, throughout my whole career. I used to go to Crayons, Boulder Fest, all of these. This movement in functional medicine started right as I was getting out of medical school. So that's kind of where I picked it up, and I'd say I never put it down. So I started out seeing a lot of ADHD and learning issues, and that moved into seeing more autism, and then Down syndrome, cerebral palsy, you name it, genetic disorders like Angelman syndrome and osteoimperfecta, and just knowing how, I guess, to see these people as people rather than their diagnosed condition, and learning how and becoming very familiar with physiology and biochemistry and how that plays out on a cellular level for all of these populations. So it's just been extremely challenging and at the same time so rewarding that I can't imagine doing anything else. So.
Awesome.
That's really awesome.
I know you said that there is that you're taking care of Down's patients, and we talked a little bit via email that there is some connection between hypothyroidism and the children you're seeing who have Downs, and maybe potentially some of the other special needs. What do you typically see?
I mean, I almost always, unfortunately, see in my Down syndrome kids, if I run all the conventional tests, I do find that they have hypothyroidism. And so then my question is, why do they have hypothyroidism? I can't just check the box like, okay, well, because common symptoms of Down syndrome are they have speech issues, they have low muscle tone, they have low energy, they have developmental delay, they have cognitive delay. This is just normal for Down syndrome. And so oftentimes that's just considered typical of this population, which I don't believe is necessarily typical. So it's all very similar to congenital hypothyroidism. If you look at the list of the diagnosis or the symptoms that go along with congenital hypothyroidism, it's very similar: low muscle tone, delayed development, delay in tooth eruption, dry skin, pulmonary hypertension, delay in cognition, poor circulation. I mean, the list goes on, and it's very similar to Down syndrome symptoms. And so I guess from the very beginning, when I started seeing a lot of Down syndrome kids, I saw this correlation, and I thought to myself, well, we constantly should be checking their thyroid, even though oftentimes in conventional medicine, they say, why even treat it, right? So I think it's really important to treat, because you can prevent issues down the road if you are looking at thyroid function, right? You can prevent. Go ahead.
It just goes back to the fact that if you have thyroid hormone in place, so many other functions that could be working may not be working. And so by just optimizing thyroid hormone, you may be able to improve, some quality of life for some of these children. Do you often see that the link between Down syndrome and thyroid issues is coming from the genetic side, or is it from lack of development from the thyroid, or is it truly metabolic at heart that may be causing some of the dysfunction thyroid-wise more at the cellular level?
Well, if you look at the data, you have a 2 times the risk of having a child with Down syndrome if you have MTHFR. If you also have MTR, it goes up to 4 times the likelihood. So knowing your genetics and having high homocysteine makes it even more of an issue. So there is definitely a genetic component, but I think there's also a metabolic component. If a mother has low functioning methylation during development, she's more likely to also have T3 not regulating her mitochondria as well. And that's going to impact cellular division. So there's lots of different ways we can go about it. Yes, I think that it's very much genetic. It can be genetic driven, but I think that if you supplement a mother and you watch her biochemistry, you can actually prevent future pregnancies, especially in women younger than 30, who I've seen plenty of mothers with Down syndrome children that have, she's younger than 30. She's not an older mother. So it's knowing how to help her manage methylation and her cellular response, and nutritional needs.
All right. So let me back up a little bit. I want to make sure I cover some points. One, when we're talking about hypothyroidism in the children, we're seeing decreased glandular function in those patients. So you're seeing an elevated TSH, you're seeing decreased T4, T3 production. Is that what you're typically seeing? Or are you seeing more the cellular model where we see elevated or upregulated reverse T3, where TSH may still be within lab range, T4 may still be within lab range, but what we're seeing is a change in deiodinase activity to the increased reverse T3.
Well, you can see both. And what I typically see oftentimes there is a frank hypothyroidism. Their TSH is way too high. Their reverse T3 is way too high, and their T3, T4 look normal or okay, which then doctors are saying, like, we shouldn't treat this, but there's obviously an issue, right?
Right. And so we'd look at that issue, and that, like in that situation, we'd say, okay, we've got T4 production, right? We're converting to reverse T3. So the gland in that situation is primarily making potentially sufficient levels of T4, but because of the stress, the inflammation, the decreased mitochondrial function, instead of T4 being converted into T3 inside the cell, the T4 is being converted to reverse T3 and pushed back out of the cell. And so then we see that elevated reverse T3, right?
Exactly.
And then, so do you see autoimmunity in these cases, or do you see more? And we talked a little, so I'll answer that question. I'll let you give me that, and then I got a part two to that.
I mean, sometimes you do, and sometimes you don't. I can't say I see more Hashimoto's in this population. It just really depends on the family's genetics, right? And if the family has a lot of Hashimoto's or other autoimmune diseases, then I'm looking even closer, like, okay, this year it didn't show up, but we should continue to look every year.
Okay. So I didn't know if there was that kind of, hey, a lot of these cases, if we took a look at thyroid antibodies, we do see that there's an autoimmune component to it. It may not be apparent in some of those cases, but they may be negative, and it's not necessarily an autoimmune issue. Is it? And there could be, as Erica was alluding to, there could be congenital issue. When we talk about congenital hypothyroidism, right, we're talking about a different set of polymorphisms that impact maybe TSH receptors, that deal with transport mechanisms, that deal with deiodinase activity, and we do see those problems from a congenital hypothyroid standpoint. The problem is a lot of the stuff we're looking at from a genetic standpoint, we don't really get all those
right.
Right? So we're not seeing all those, but in a true congenital model of hypothyroidism, we see this kind of dysmorphia, this abnormal growth and development. So it'd be interesting to figure that out, and maybe it's something I take a look at down the line. But part two, you thought that was part two, but that's not really part two. But part two is really, do you often take a look at the patients and go back and look at mom and say, okay, was mom hypothyroid prior to pregnancy?
Yes.
Do you see a high correlation there?
Sometimes, not all the time. But usually I find that if I go back and look at her homocysteine levels, if I go back and look at how her methylation was probably functioning back then, that's what I do find. But a lot of these moms aren't hypothyroid necessarily.
Okay.
Right? They're young. They're 24-year-old, 28-year-old women that ended up with a Down syndrome child, and everybody thought they were perfectly healthy people. Nobody had found an issue before this. Yes.
And so my experience with Down syndrome isn't very vast, but is there a consensus view, conventionally or from a functional standpoint, as to primary triggers? I mean, we were talking about, you and I, we're talking about methylation here, and some of our viewers have probably heard that term before from us, but methylation may be a component, maybe thyroid physiology breakdown is a component. Is there other kind of agreed upon causes?
I mean, the big ones are a high homocysteine, right? And advanced maternal age and genetic SNP, those two genetic SNPs. That's the primary reason why they think people have more likelihood of having a Down syndrome child.
And that's a high homocysteine in the mom.
In the mother, because it's opposite in the Down syndrome child. They usually are low homocysteine.
Okay.
So, yeah.
When it comes to a Down syndrome child coming in, are they coming in looking for like alternative care, or are they coming in with the symptoms that the mother's bringing them in and saying, you know, my son or daughter has this or this, can you help us? You know, what is the reason they land at your office?
So a lot of times it's energy. So my older kids that I see, that's primarily why they bring them in, is their energy is really low. Their concentration, their focus, they have behavioral problems. Those are my older Down syndrome children that I see. And then I've seen a huge influx in the last few years as I've studied genomics, that all these mothers want to do the best that they can in order to help their babies that are 6 months, 3 months old, develop the best possible way that they can, right? So we want to prevent any kind of cognitive delays. We want to make sure that they grow correctly. So the earlier I see them, the more changes in that way that I can make. When I see the older kids, of course, there's a lot we can still do, but they're usually coming in with symptoms if they're older. And it's those symptoms of weight gain, exhaustion, their inability. I'm just thinking about one of my older kids. He fell asleep on the bus every day, or his mother would pick him up, and he'd have to sleep for 2 hours after school every day because he was so exhausted. And so in all of these cases, I have to figure out why. It's not just putting them in the box of you have Down syndrome, these are all normal things for you, but why are you feeling so tired? What's happening on a thyroid level, right? What's happening on the organ level, and what's happening all the way down to a cellular, like the organelles of the mitochondria. How well are those functioning? Because we know that oxidative stress is a huge problem in this population, which drives that reverse T3. So there's a lot of different important questions to ask yourself, and testing, I think, is really important. So
are these kids coming in knowing that they have thyroid issues, or is that something in the kind of slew of tests that you run that you uncover?
The brand new little babies that I see in my practice, a lot of them, their parents have run thyroid testing because they're up and they're very knowledgeable about what to test for, and they're hounding their pediatrician to test, and then the pediatrician shrugs their shoulders like, we're told not to treat Down syndrome, hypothyroidism and Down syndrome. And so then they seek out somebody like myself or somebody like you to help them navigate this really complex system. So yeah, that's usually, it just depends on, you know, how educated the parent is. And then there are a lot of other patients that I'd say 10, 15 years ago, I was testing them. I was looking for, what's your thyroid doing? Because they're coming in and they're tired and they have speech delay and they have all these behavioral problems, and nobody is looking for answers. They're just kind of checking the box, Down syndrome. So
yeah, I think we have to be really careful, and we have a tendency to do that in conventional medicine to a large degree, and even in functional medicine to some degree, and that is diagnosing and labeling somebody and then treating the diagnosis, right? So you talk about a metabolic matrix of physiology rather than a person with Down syndrome, which is, I think, a great term. I know with a lot of my patients that come in with chronic, they got hypothyroidism, but they got digestive issues and they got adrenal issues. And really what a lot of people want to know is just, what's the name of what I have, right? And they just want to know what is it I have. They're looking for something to hold on to say, okay, I've got X. Now give me the treatment for X. And some people don't want that. They've kind of figured out that model doesn't work too well. And when I have patients that push me on, okay, so what's wrong with me? I usually use a different term. I call it a multi-system dysfunction disorder, because their adrenals are dysregulated, their gut's dysregulated, their neurophysiology is dysregulated. And so what's wrong? Everything's wrong. And everything's wrong. And at the root of it, and it's probably based on what you're saying, is that the root of this, especially for these kids, is really an inflammatory component, right? Because
yes.
If they've got MTHFR issues, if they've got methylation issues, they poorly generate energy, they produce more inflammation, they can't produce the glutathione that's needed to really be antioxidant in nature and kind of calm that whole cascade down. I haven't looked into the correlation, but my heavy science or study right now is on NRF2 pathways. And so there's probably some huge impact there with what's happening with NRF2 not being able to do what it needs to do. So I think using a term like that is probably helpful versus maybe Down syndrome, because now you go, okay, what's the traditional treatment for Down syndrome? You do X and Y, and that everything else is normal. Well, none of that physiology is normal, correct? It's just common in that group that we've labeled with a name. And really where the real doctoring comes in is to say, okay, we've got these signs and symptoms. Now my job is to help you uncover what some of those mechanisms are and what we can do now to restore physiology. Is that kind of how you look at it?
Beautiful. Yes, that's exactly. It's just remembering that these people, they can function better if we understand them on a cellular level, all the way up to their macros. So understanding that, I mean, I'll go back. So yeah, it could be that gene. I don't know about, did you say NRF2? Is that what?
NRF2 is like the regulator of anti-inflammatory immune pathways, huge activator of antioxidants, glutathione. It's like, it's what drives glutathione production.
Well, and glutathione is incredibly low in this population, and part of that is because they have low homocysteine and they have a CBS that works over time. Like they have a 50% increase because because it's controlled by chromosome 21. On chromosome 21 is your CBS and your SOD. So CBS is on overdrive, and SOD produces all this hydrogen peroxide, which ends up messing up their glutathione levels so that they don't have as much glutathione, and then all of a sudden they have this oxidative stress. And then how do we deal with that, right? Because that makes more reverse T3. Now, knowing that, at the same time, I think, again, treating them like an individual, like some people with Down syndrome are going to have a different expression than, say, 50% of that CBS, right, going towards using up all their homocysteine. So again, you treat them like an individual, you go back, you test, you want to know what their antioxidants look like. You do functional nutritional assessments, right? And look at vitamins and digestive support and essential fatty acids and their amino acids and their detox pathways. I mean, we can get into more of that, but I think testing and knowing exactly what they need, what they don't need, knowing that the pathophysiology of Down syndrome has these things in it and paying attention to that, but not necessarily just saying, oh, they have it, so we've got to do this. It's not that cookbook medicine, right? It's individualized medicine. So,
and we talk about that at ShyCon, and
yes.
Ed and I beat that down quite a bit.
Mm-hmm.
I know Dr. Eric and I have talked about it's not formulaic. Just because you have X doesn't mean, if we go to SNPs, which a lot of people think about is, I have this SNP, what cofactors do I need to take and how much? Is that going to fix everything? Well, no, because sometimes one SNP is downregulated because another one's upregulated, or vice versa. Maybe there's more inhibitors inhibiting the gene, and the SNP is a minor factor. And it's the things that are inhibiting gene function or upregulating gene function that are probably the bigger factors that need to be addressed, not more B6 specifically. Mm-hmm. Now, when you talk about CBS upregulation, and for our listeners, CBS is an enzyme that converts homocysteine down something called the transsulfuration pathway, and that can help with detox pathways, but it can also help make something called glutathione, which is the major antioxidant in the system. Now, if CBS is upregulated, are you typically, I don't know, testing homocysteine and oxidize and reduce glutathione is a little bit harder thing to do, a little bit more expensive at times to do. Are you testing that to find out, are they just, because that CBS has been upregulated, do we know if they are just nutrient deficient to keep up with the pace, or is it that they're making glutathione and can't recycle it? Do we know what we typically see?
They usually have both problems. They don't have enough homocysteine to make their glutathione, right? Or methionine to make CME. So it ends up backing up into the folate cycle, where they need a lot of support. Like riboflavin is huge in this population. They need riboflavin support. But again, I'm not going to just willy-nilly say, okay, I'm going to give you some riboflavin right now. I'm going to test them first, right? I'm going to run a nutritional evaluation, whether it's a SpectraCell or a Genova Nutri-Eval, to see where their levels are at and what we want performing. So you look at it all together, right? You don't just look at one piece, because then you're going to get yourself in trouble, right? Mm-hmm. And then they have high cysteine levels, really high cysteine levels typically, and they can't do much with it, right? They can't take that cysteine and make it into usable glutathione. Okay. So it's a lot more complicated, right? This is where cookbook medicine will never work. You know, you can't say, take this supplement for the rest of your life, you're going to be fine. It's really about dialing it in, knowing exactly what they need, when they need it, when to go to go in and out of these metabolic pathways.
And I would agree with all of that. And the challenge is that, when and not necessarily the patients that you're treating, but a lot of people come in with preconceived notions that is it a B6 issue? Is it this issue? And don't realize that it's way more complicated than that. And because you need a certain amount of B6 today, doesn't mean you need the same amount of B6 a week from now or 2 weeks from now. right? And the body's variable. The other thing, and we've talked, Dr. Eric and I have talked about this before, is people assume I have a SNP or I have a condition, and B6 helps somebody else I know with that. And when I take B6, I have an allergy to it because I react negatively. And my contention of that is that B6 does what the body needs it to do to protect itself at the cellular level, right?
Mm-hmm.
So if you take B6 and your body is under a heavy stress response, that B6 may go through one pathway that's really more important versus the pathway you want it to go through. And riboflavin is a great example of that. It may be used to upregulate MAO, not to be converting MTHFR, so or to be related to fat metabolism. So the cellular system, there's an intelligence there which is going to do what it can for the survival of the cell, not necessarily what we sit back and read a blog post on the web or a Facebook page and say, oh, well, if that works for them, it's got to work for me, and then say, oh, well, B2 shouldn't work for anybody because it didn't work for me.
Right. Absolutely. I agree 100% with what you're saying. And it's unfortunate that a lot of people they get a little bit of information and they feel like that's the answer when it's a little bit more complicated than that. But again, if you're running the right tests, you can find out, are you deficient in riboflavin? So you're not making that FAD, and if you don't have enough T3, you're not converting that FAD into a usable form to use in all of these pathways. So it all doubles back if you put it all together. It just takes putting it all together.
Right, and that's where all that education and time away from home and all that stuff comes into play.
Right.
But let's talk about testing. So you hinted on testing a little bit.
Mm-hmm.
Kind of, what are some of the kind of foundational tests that you're using to take a look at these children as they come in?
Well, conventional testing would look like typical TSH, T3, T4, reverse T3. Homocysteine, you can do zinc and copper in a normal lab test. As you know, those show up pretty well. The other vitamins we'll talk about and nutrients don't show up so well on a Quest or a LabCorp. I always look at iron and ferritin. I'll run a CBC and ChemScreen if I need to. That just gives me overall view. A lot of these kids have already run those, so I don't always run them. But again, also assessing vitamin D, both the 25-hydroxy and the 125-hydroxy, the active form. And then genomic testing can be helpful. I don't necessarily have to have genomic testing to kind of understand how this biochemistry is playing out if I can run some of the other tests, but sometimes it can help. So understanding maybe on top of the fact that we already know that this population doesn't methylate very well. Well, if we also run genomics and see they have MTHFR, they have MTR, and knowing that they're high in oxidative stress, we know that that is a double whammy on that folate cycle. Knowing maybe they have some SNPs and CBS that actually slow it down a little bit, which would be helpful, right, in this population. So sometimes I think that can be helpful, genomic testing, but we have a lot of understanding even without running that, and it's getting a little bit more complicated these days. Hopefully we'll have a good test coming soon. Nutritional testing, I feel like is really foundational. I think it's so important to run either a SpectraCell to know what's inside a white or a red blood cell. So many different conditions, as you know, may have plenty of folate and B12, methylcobalamin or cobalamin itself outside of the cell. You may see really high levels, but inside the cell, there's nothing bioavailable. And so we need to know what's bioavailable. So you probably covered this in the past, but this population, again, you need to know what's making it into the cell. What's protecting that cell? Do you have the antioxidants you need? Do you have the minerals? Do you have the B vitamins that you need in order to do that? So I usually use either SpectraCell or the Nutritional Evaluation, just depending on how much the family can spend on testing and what their insurance is, because I try to keep tests reasonable for them. You know, an organic acid is really it's a go-to for me. I love Great Plains. Again, that Nutrival has it on it if I have to run it through their lab. Doctor's data looking at the methylation pathway is often helpful in this population to know, like, Do they have enough methionine? Do they have enough homocysteine? Do they have B12? Do they have B6? Like what do we need here? And what are those levels? And what's that SAM-SAW ratio? So that's helpful for me to know. Digestive, how well are they digesting? How much inflammation do they have? Do they have enough essential fatty acids? Do they have the amino acids they need in order to function properly? Do they have enough glutathione? Because in this population, glutathione is really low usually. Lipid peroxidases are really high in this population, which again, if we can get the thyroid under control and limit their oxidative stress, I mean, we can make a huge dent in these symptoms, and they can have more cognition. They can grow taller. They can have less metabolic diseases like cardiovascular disease or cholesterol problems because we're managing their thyroid. So, so it also gives us a peek at their neurochemistry if we run that organic acid, and oftentimes this population is really low in serotonin. They're also really low in acetylcholine, which contributes to that low muscle tone along with the mitochondrial issues. So knowing, some of the precursors, is there choline? Do they have enough choline to make acetylcholine? Do they have enough choline in order to make the CME that they need to make, in the methionine cycle? So some of these tests are really helpful. And then, icing on the cake wouldn't be environmental testing, knowing that their CBS is not probably working so well, so they're going to be more susceptible to environmental toxicity, whether it's pesticides, whether it's heavy metals, whether it's high ammonia levels, whether it's sulfur issues. I like to look at those. And then finally, I think another really important area to test is food sensitivities, because we're trying to reduce inflammation in this population. We're trying to bring down oxidative stress, and our GI is one of the most important places we need to focus on. I mean, that's at least a natural.
Yeah, I totally agree. Yeah.
No, I totally agree. A lot of this population has slow motility inside the digestive tract.
Yes.
Do you do any sort of GI testing, whether it's stool sample or looking for SIBO or any of those, tests that go along with the digestive system?
Well, once we look at thyroid, right, and then we look at, we usually look at a CSA or GI effects. Whoever you like to run, diagnostics has another test that some people prefer, but looking at microbiome, because of course the microbiome is at play here, that's going to give me clues into whether I need to go down the SIBO route. I don't always go there with this population. It's more important to me that they have adequate choline, that we're taking care of their mitochondria, that their thyroid is really addressed in the appropriate way, and then I'll go looking for other reasons why they may have constipation.
Okay.
Did that answer your question?
Yes, absolutely. And then on top of that, if they have thyroid issues, the motility is even going to be slower. So if you're working on thyroid physiology, that may help all of that stuff.
Exactly. And that's what I like to go for, the horses rather than the zebras, right?
I think you start with the foundational issues, definitely. I mean, you got to look at the big picture things. Then before you start working on micronutrients, you really got to consider the fact that if I put these things into the system, is this a person who's going to absorb them? Am I actually just feeding dysbiosis?
Right.
A lot of our gut flora, if it's healthy, provides a lot of nutrients for us. So that's really important. I think one of the things I was going to ask is do you see a fairly consistent connection between gut physiology problems in these patients? Do you see that that's a common theme?
Well, I think our microbiome is dictated by all of these cellular functions. Wouldn't you agree?
Yeah.
So I think it's the chicken and the egg, right?
Yeah. I just wondered if you when you do a test, you say, yeah, there's dysbiosis here. It's a pretty common theme.
Usually.
Something pretty likely that you're going to have to address. And so again, that comes back down to a foundational issue. Interesting. It's something when you guys were talking about acetylcholine, do you see that this population, and probably, I don't know that anybody's testing, but I know you have your Oura ring on, is this from a population standpoint, do a lot of these kids have challenges with their sleep cycle?
Yes.
because that would make, there's a huge tie in there to acetylcholine function, sleep,
Yes.
and gut function, right?
And
So,
serotonin.
yeah.
So, and melatonin production, which you have to be careful. From the research I've done, I can't use melatonin and resveratrol as fast as I might like, because they both upregulate that SOD, which makes more peroxide, hydrogen peroxide. So it's complicated, but yes, serotonin is usually a big issue, and melatonin production in this population, and their sleep is definitely impacted. So is their adrenals, right? Which, going back, adrenal function is going to impact all of these systems. So it's finding ways to get them to sleep, right? It's really important to go back to the basics of sleep with parents, right? That you can't even have a nightlight in their room. Reduce any blue light. Make sure that their blood sugar is balanced throughout the day so that they can sleep a little bit better. That's because they have good better liver function. You know, the better their liver is functioning, the better they're going to sleep. So yes, it's tying all of these things back to all these systems, but sleep is a major component. Yes.
Yeah, and definitely acetylcholine could be one of those things too. And I pulse that. I challenge my patients. Some of my patients have sleep issues with some acetylcholine, especially if they have bowel issues. And for a lot of them, that really can help. The other piece, when we talk about serotonin, and Dr. Erica and I have talked about this probably 50 times already, and that is that anytime there's a stress mechanism going on, infection, inflammation, not only is T4 to T3 decreased and increased reverse T3, but tryptophan, which is a precursor for serotonin, is upregulated down the chynurenic pathway. So you get more quinolytic acid, which is a neurotoxin, which is going to make them more agitated, more irritable, and that too can have a big impact. And we have to be careful as physicians, and I know you're well aware of this, that if we try and force more serotonin production, we can unfortunately upregulate MAO activity, which is going to increase hydrogen peroxide and deplete our B2. Because one of the things that happens when there's inflammation is you get upregulation of IL-6, one of those inflammatory chemicals, and that actually speeds up MAO activity. And I'm not sure what the population is with already having SNPs, but part of that natural cell danger response is to convert tryptophan away from serotonin and melatonin production and increase the clearance of serotonin out of the body. So, and sometimes it can be helpful to give some 5-HTP to support serotonin production, but we also have to realize that it is going to be metabolized, and if we already have glutathione deficiencies, we may get a short run of benefit, but we may have a long-term downside to that. I'm not sure if you've seen that.
Yes, it's a long-term consequence, and I see that in my autism population as well, right?
Yeah.
So, yeah, you have to be very careful with 5-HTP and especially tryptophan, and then understanding what their microbiome is like, right? So you may be giving some of these nutrients and find that you're feeding microbiome, or there's a big yeast component in some of these cases. That's why another reason, okay, well, that could be also impacting their serotonin levels, right? And their nutrition, like their B2, their B3, their B5. All of those are impacted. So, and their minerals. So it's looking at these tests to see, okay, well, what are all the factors that we're looking at here? Not just like, oh, you have Down syndrome, we're going to put you on some 5-HTP. So,
right.
yeah.
So
I know we've talked a little bit about, the changing the diet and the sleep habits, and supplementation, but what are some other lifestyle factors that you often try to change or encourage them to change in this population?
So I go back to our foundations of health, right? I go back to, getting exercise, getting out in the sunshine, teaching children, no matter if they have Down syndrome or they're neurotypical or they're autistic, modeling deep breathing for them and helping them learn how to deep breathe. Then there's eating organic, right? Reducing any kind of oxidative stress and the pesticides and all of the things that they could be, heavy metals that they could be contaminated with if they're not eating organic. Even organic rice, of course, though, still has arsenic in it. So it's helping them make the best lifestyle choices and helping them understand, okay, well, if you have Down syndrome, and we have a yeast infection going on or a yeast overgrowth in the GI, maybe we need to shift to a lower carbohydrate or low glycemic diet for a while, get the yeast out of the system, and then eventually we can put some complex carbs back in, but no fried foods, no food coloring, no high glutamine foods, because that glutamate GABA balance is way off in both autism and Down syndrome. So it's finding ways to, increase GABA and take down the glutamate. So what would that mean? No more Dorito chips, right?
Oh.
No more of these processed foods, and trying also to educate them. The longer you let bone broth brew, it's going to have higher glutamate in it. So you may be doing the right thing by making your bone broth with an organic chicken, but maybe you're cooking it too long and the glutamate's too high. So it's some of these lifestyle changes, drinking enough water during the day, getting the electrolytes they need, sweating, whether you're going to get them in an infrared sauna, which some of them will do, and whether you're just going to run around and play tag outside, which this population is one of the sweetest, most kindest, most generous populations you'll ever meet in your life. They're absolutely a blessing. So it's laughter, it's sunshine, it's all of these foundations to health, I think.
That's awesome. Yeah, no, I love that. So
I know you our buddy Mike Mutzel, right?
Yes.
And Mike's done a couple things. It's a big piece of the work that he's doing. It's a huge thing that I do in my practice, and try and get people to breathe appropriately, right? Mm-hmm. Because of MTHFR issues and developmental issues, I'm interested, do you see that this population is more of a mouth breather population because of those changes? Because that would definitely create some major impact from a sleep and rest cycle and recovery cycle at night. Do you see that a lot of them are mouth breathers by nature?
Yeah, they have tongue perfusion. That's part of kind of the diagnosis of Downs. They have speech problems because of that tongue perfusion. So it's teaching them how to actually posture, how to sit up straight, how to actually have more core engagement so that they can sit correctly. So hippotherapy, which is a horseback riding program for these kids, is phenomenal just to get them to sit up correctly and get that those core muscles engaged. And then they need the nutrients for the cells, right? To stay engaged. But breathing, this population, there's a lot of mouth breathers. They have a lot of inflammation that causes those adenoids to be really, really big and tonsils to be really big. But do we want to take them out? No, we don't. We want to figure out, how do we decrease inflammation? How do we find ways in order to get them to be able to keep their tongue further back in their mouth and breathe through their nose? And sometimes it just takes a lot of awareness, and they can learn. That's the beauty, is they want to feel better. So a lot of times if you slow down and take them through, and I have a graphic that shows how long should a deep breath take, and then how long should an exhale take. And having a visual graphic for this population is very helpful.
Okay. Are you, in taking a look at some of the work that you're doing, some of the supplemental support, especially from an antioxidant state, have you used sulforaphane or broccoli sprouts as a way to upregulate the anti-inflammatory processes?
I mean, we've talked about foods like sprouts, like broccoli sprouts, and they also increase your glutathione, which is good, right?
Well, yeah. So the sulforaphane, and the reason that's important, I bring it up, is it's one of the things that with Jason and US Enzymes and the gang there, we're actually formulating a sulforaphane product, because sulforaphane is the biggest upregulator of the NRF2 pathway. Therefore, it upregulates all the antioxidant pathways. And the problem with NRF2 is it only has about a 20-minute half-life, so it goes away pretty quickly. And chronic inflammation can actually inhibit NRF2. Chronic inflammation, chronic infections will actually inhibit NRF2 pathways. So that essentially depletes our body's ability to make the stuff. So it may not necessarily always be a micronutrient deficiency, but just a alteration in the chemistry of the body caused by some of these chronic inflammatory issues that especially these poor kids have had since early on. So it may be a thing to maybe consider even kind of looking down that pathway at the sulforaphane as an upregulator. If you can get them to eat sprouts, that's awesome. But that probably got to hide those somewhere. But it is the broccoli sprouts are 100 times more potent in their sulforaphane than regular raw broccoli or even cooked broccoli. So really powerful for upregulating NRF2 pathways. So there's a lot of research being done on that now. So I think it's going to be huge versus just trying to give glutathione's good in the short run, but trying to figure out how to upregulate all those pathways from a healthier perspective. I think sulforaphane, which is a food-based product, gives us a huge boost in the potential to do that. So I think that's pretty cool. But it'd be interesting to see if it is helpful for some of that population. I should send you. Remind me. Shoot me an email. Okay. I'll send you a bottle or two of the product that we just formulated, and you maybe test that out and see how that works on somebody.
And could we unload that capsule? A lot of these kids can't swallow caps.
Yeah, it's totally unloadable. Yep, you can open it up and put it in something and it'd be fine. Yep.
Okay, great. Well, fascinating. I'm always up for learning and finding new answers. So that's fantastic. Thank you.
So I think we did a good job. That was a little over an hour, I think, right? So I think what we'll do is we'll wrap this one up. Why don't you give us a little background? I'll put it in the show notes, but if you give us a little background about if somebody has an interest in talking to you about Down syndrome, special needs kids, or just looking for more information about what you do, how can they find you?
So I have a website. That's probably the easiest place to go. It's just theprattclinics.com. So I'm Dr. Pratt. So it's Pratt. So the Pratt Clinics. It's an S because I have two. My husband wants me to start third, but I'm not doing that yet. He loves Sedona. So we'll see. We'll see how that goes. But anyway, so theprattclinics.com, that's my website. If you go to the contact page, you can sign up for my blog. You can find our phone numbers. You can find our address. You can find our email. And we'd be happy to answer any questions in the future.
Awesome.
So, yeah.
Well, we appreciate you coming on. There was a lot of information covered. I'm sure I'll go back and listen to this again, see if everything sunk in. But we really appreciate you coming on. We'll be I'll reach out to you again. We'll get you on maybe in another 6 months and have you give us some more beautiful information about what you're doing and give us some new insights. But really appreciate it. Hopefully you don't have to fly too many times back and forth across the country because that'll deplete your own adrenals and thyroid physiology. So, but thank you so much for coming on. Erica, any final thoughts?
I just want to say thanks for coming on. What you're doing is amazing. And so that population needs help, and there's not a lot of people who are doing holistic to help support them. A lot of times, again, they're just being put into a little bucket and they're not getting the help or the optimization that they really could. So I think that you're doing an amazing thing.
Thank you so much. It's such an honor to be on here. Thank you so much for having me.
You guys, so we'll wrap this one up. Dr. Eric and I talked about where we are, and you can find us on our websites. The information is usually at the bottom of wherever you're watching the video. If you get a minute and you're enjoying the information you're getting, please go to iTunes and check the box and give us a nice plug so that we get more reviews on there, and that kind of raises our ranking on there. More people can find us. So thanks so much for coming, and we'll wrap this one up. Let's shut it down, Erica, okay?
All right.
All right, take care.